Hi everyone, my name is Madison Paddock, and today I'm going to talk to you guys about a couple of the diseases of the urogenital tract. So those will include trichomoniasis, chlamydia, and syphilis. So just a little overview for you guys on what we're going to completely cover. At first, I'm going to talk to you a little bit about STIs in general, just some quick facts that are good to know, and then get into trichomoniasis, chlamydia, and syphilis and their history, the actual causative agent itself, how they function and their mechanism, some signs and symptoms, diagnosis, epidemiology, and treatment. So up first, we're going to cover that STI overview. So, what are sexually transmitted infections and how common are they really? So just some quick facts on those sexually transmitted infections. More than 30 bacteria, viruses, and parasites are known to be transmitted through sexual contact. And according to the World Health Organization, more than 1 million sexually transmitted infections are required every day worldwide. And the majority of those infections are of people who are asymptomatic. So STIs can affect both men and women of all ages, and they have a direct impact on our sexual and reproductive health through stigmatization, infertility, cancer, and pregnancy complications. And then as of 2022, the most common STIs are HPV, HIV, hepatitis, chlamydia, gonorrhea, herpes, syphilis, and trichomoniasis. So at first, we're going to talk about trichomoniasis. So just some background on trichomoniasis. It is caused by a parasitic protozoan known as Trichomoniasis vaginalis, and it is commonly referred to as trich. It was discovered in 1836 by a physician named Alfred Francois Dunn, and it was observed in motile microorganisms in the vaginal discharge of infected women. So although he founded it in 1836, it was not clinically identified as an STI until about 1916. So despite all these early breakthroughs, research was not actually conducted on it until the 20th century, and today it is considered the most common non-viral STI. So when I came upon researching trichomoniasis, I came across this little bit of a figure, and I thought that it kind of easily described the structure of trichomoniasis. So we have a single-celled protozoan that has a nucleus in the middle, and it is amoeboid shaped. Is amoeboid shaped when it is attached to cells. It is usually oval shaped when it's just hanging out in culture. So you can see on the right side there are 4 anterior flagella that help the cell move around, and then we have you can see that little like pink ring kind of on both sides. That's called an undulating membrane, and basically the function of that membrane is it kind of works as a mouth, and it helps the cell take in any nutrients that could be floating around, and to kind of help it grow. Just a quick note here, trichomoniasis infects the vagina in women and it infects the urethra in men. So a little bit of more information about the causative agent and its mechanism. Like we said before, it's a one-celled parasitic protozoan, Trichomoniasis vaginalis. In culture, it's in that oval shape, but it's generally amoeboid shape when attached to the cell. One note about the agent itself is that it releases cytotoxic proteins that destroy the epithelial lining, so this can result in actual tissue damage if left untreated. It contains the undulating membrane, and it is anaerobic and flagellated with 4 anterior flagella. It is found only in trophozoite form and does not form cysts, and is commonly found as a normal part of the normal vaginal microbiota, which I did not know. So this can cause vaginitis if there is a disruption to our normal microbiota. So it functions to divide by binary fission, which gives rise to population in the lumen and on mucosal surfaces. And it functions by adhering to cells using adhesions such as lipoglycans. And it also has other cell surface virulence factors such as tetraspanins, which are involved in cell adhesion, motility, and tissue invasion. It is also capable of phagocytosing other microbes. So this is problematic because it can destroy or harm our normal vaginal microbiota and other microbes that could be helping us, which contributes to the development of that imbalance favorable to infection. So moving on, we're going to talk about the patient's symptoms. Trichomoniasis has an incubation period of 5 to 28 days. in which men are generally asymptomatic. So women are also usually asymptomatic, but they are more likely to develop symptoms as compared to men. So symptomatic men may experience itching, irritation, needing to urinate more than usual, a thin white discharge from the penis, swelling around the head and or foreskin, and burning after urination or ejaculation. For symptomatic women, they may experience dysuria, redness, itching, burning, soreness, painful intercourse, cloudy urine, a tender pelvic area, an abnormal discharge that may be thick, thin, or frothy with a yellow-green color and an unpleasant fishy smell. Another telltale sign that someone may have trichomoniasis for a female is called strawberry cervix. If you look it up online, it's a cervix that basically resembles the seeds that are on the side of a strawberry. It has little red dots on it. So that can be a telltale sign and is seen in about 40% of patients. They are also at an increased risk of transmitting and acquiring HIV, and trichomoniasis is associated with pregnancy complications such as preterm birth. So diagnosis for trichomoniasis, we see wet mounds being used. So for women, a sample of urine or vaginal or endocervical specimens are used. And for males, we see a urine or urethral swab. So the sensitivity method of these wet mounds is low. So it's often combined with nucleic acid amplification testing to help increase sensitivity. There's also a rapid test called the OSOM Trichomonas rapid test, which is used with a DNA probe test to test for multiple species that are associated with vaginitis. And also, it can be detected on a pap smear, which usually women get annually once they reach a certain age, which is usually 21. So this isn't really considered a good diagnostic tool due to a high rate of false positives and negatives. But in the event that someone has a positive test and is positive for it, it can be a good step to helping that person, get further testing and the treatment that they need. So trichomoniasis, the treatment for it is unlikely to go away without treatment. So treatment is recommended for both the patient and the partner. This is to help avoid transmission to others or back to the patient. So it is treated quickly and easily with antibiotics, and is recommended that the person that has it avoid sexual intercourse until the infection completely clears. And the antibiotics that are used to treat it are called antiflagellant oral antibiotics. So a couple examples of these are tenofovir, secondazole, and metronidazole. And the typical dosage for these is 1 pill 2 times a day for 5 to 7 days. And then after completing the course of antibiotics, it is recommended to retest 2 weeks to 3 months to ensure the infection is completely cleared. And some final notes on trichomoniasis in regards to its epidemiology. It is estimated that in 2018, 2.6 million people had a trichomoniasis infection. Among those, it is more prevalent in women. We see about 2.1% of the population between the ages of 14 and 59 with trichomoniasis infections. But something I found interesting is that it actually is most common in women between the ages of 40 and 49. It is still common in men, with about 0.5% of the population in between the ages of 14 and 59 having an infection. The CDC also discusses a study that was completed on women, and in that study they found that 9.6% of African American women, 1.4% of Hispanic women, and 0.8% of non-Hispanic white women had infections. So some risk factors that aren't limited to trichomoniasis, but it's also covers for other sexually transmitted infections. Some risk factors include a previous STI history, new sexual partner or partners, multiple sexual partners, and no use of barrier contraception such as condoms. So moving on, we're going to talk a little bit about chlamydia. So a couple notes on the history of chlamydia. The causative agent is a bacterial infection, and the bacteria is called Chlamydia trachomatis. It was discovered in 1907 by researchers by the names of Halberdister and von Prouzak, and they found this bacteria after observing the conjunctival scrapings of an experimentally infected orangutan. So this was the first recognized bacterial STI in the 1970s, but it took until about 1980 for it to become a notifiable disease, which means that anyone who tests positive for the disease, it has to be reported to the CDC so that they can keep up-to-date epidemiology statistics. So some information on the causative agent. The bacteria, like we said before, is called Chlamydia trachomitis, and it is a gram-negative obligate intracellular pathogen that is extremely resistant to cellular defenses, which aids in its ability to spread rapidly from host to host. It is found in two different forms, the cocci and ovid, and it primarily targets epithelial cells of the urogenital tract and conjunctiva. It is also known to cause infection of the lymphatic system, known as lymphogranuloma venereum, which someone else, I believe, is talking about in a presentation, so I won't go into too much information regarding that. And then finally, it is transmitted by oral, vaginal, or anal sex, and sometimes can be transmitted from mother to newborn baby during a vaginal delivery. So this is a screenshot that I actually took from a Khan Academy video in which they discussed the pathophysiology of chlamydia, and I thought that it was a really good source for you guys to be able to figure out how exactly chlamydia spreads within our cells. So we can see over on the left top hand corner we have a white blood cell and a bunch of these little green dots, which are called elementary bodies, and the elementary bodies are the actual chlamydia bacteria. So our white blood cells will take in the chlamydia bacteria, in which that is called phagocytosis or endocytosis. So it is taken into the white blood cell and it is held basically in a phagosome or an endosome, depending on what kind of cell. And then moving on, as it's inside of that phagosome, it will start to take in some of the nutrients and components that are inside of that cell, because in order for chlamydia to live, it must live inside of a host cell to reproduce. So once it started to take in some of those nutrients and grow in size, it will then be called a reticulate body. And through binary fission, it will continue to replicate. And you see that the phagosome is just continuing to grow in size and taking up the majority of the cell. So once those elementary bodies and reticulate bodies decide that they want to leave the cell and go infect another one, more elementary bodies will be produced until the white blood cell eventually ruptures. And this will cause the release of those reticulate bodies and elementary bodies. And then those elementary bodies will go on to find other white blood cells to infect, which contributes to the infection spreading to other cells. So moving on to some patient symptoms. Most commonly, patients with chlamydia are asymptomatic, but when symptoms do appear, females will typically experience painful urination, vaginal discharge, painful sexual intercourse, bleeding between periods and after sex. Some more severe infections include urethritis, salpingitis, pelvic inflammatory disease, endometriosis, ectopic pregnancies, tubule factor infertility, and an increased risk for cervical cancer. For males, when they experience symptoms, this includes discharge from the penis and testicular pain. Some more severe infections may include non-gonococcal urethritis and epididymitis, alongside orchitis can also occur. We also can see chlamydia infections in the rectum, so these people can also be asymptomatic, or there can be rectal pain, discharge, and bleeding. And we also can see on the right side here, chlamydial eye infections are common if someone were to come in contact with an infected fluid. So the way that chlamydia was described to me and through my research, I found that it is usually separated into two different types of infection. So the first being a primary infection. So that's the first time that you get chlamydia, and that is a serial infection of mucosal cells which secrete chemokines and cytokines. So these cytokines cause vasodilation, increased endothelial permeability, and elevated expression of adhesion molecules. So this can allow for bacteria to spread via lymph vessels to lymph nodes, and that can cause an infection of the lymphatic system, and it's common in the groin, and that's the lymphogranuloma venereum. So this is most commonly found in tropical regions and can co-occur with HIV. So this is when the microbes invade the lymphatic system and bulbos will form and burst, releasing pus through the skin. And this can cause male genitals to become enlarged and female rectums to become more narrow. So in this primary infection, it's really important for T lymphocytes and for IgA to knock out the infection to avoid any reinfection or chronic infections from occurring. So the next type of infection is a chronic infection, which is just a fancy way of saying reinfection or reoccurrence. So this can sometimes be considered a delayed hypersensitivity or type 3 reaction. So in this, we see that the bacteria from the primary infection basically hide in our macrophages and find temporary shelter in our lymph nodes, spleen, and serous cavities, causing that lymphogranulonum venereum. Reinfection can also lead to physical tissue damage, fibrosis, and keratoconization, which is a fancy way of saying scarring within our infected organs. And then some irreversible consequences, such as pelvic inflammatory disease, that can lead to mechanical infertility, ectopic pregnancy, chronic pelvic pain, and chronic urethritis. So the treatment for chlamydia, we have in women, vaginal and cervical swabs are used to diagnose. Sometimes a urine test will be used alongside those swabs to confirm. In men, we see urethral and urine samples used to diagnose, and we see those nucleic acid amplification tests used to confirm. It is treated with antibiotics, so the most common ones being doxycycline, which is taken every day for a week, and azithromycin, which is 1 dose of 1 milligram followed by 500 milligrams once a day for 2 days. So depending on the severity of the infection, other alternatives may be used, such as erythromycin, levofloxacin, and olefloxacin are alternatives. And we see those antibiotics used for the patient and also their partner to help avoid that transmission to each other or to other people. So next we're going to talk about the epidemiology. So according to the CDC, it is the most common bacterial STI in the U.S. It's actually difficult to account for the number of cases because many people who have chlamydia are asymptomatic and don't actually seek testing on their own. But of those, we see it more common in females than males, but that is most likely due to a lack of testing in males. Like I was saying before, pap smears can help detect a couple of different STIs. And since women typically get these tests yearly once they reach a certain age, they're more likely to be tested for that STI than males would be. So about 2/3 of new chlamydial infections occur among the ages of 15 to 24 years. In 2019, we see that more than 1.8 million cases were reported of chlamydia. It's estimated that 1 in 20 sexually active women aged between 14 and 24 have chlamydia. And we see some disparities among racial and ethnic minority groups. So in 2020, a study was conducted and found that African Americans and Blacks were 6 times more likely to have chlamydia than white people. So it was recommended to kind of lower some of these statistics. It's recommended that routine screening is completed on sexually active women under the age of 25 who are considered high risk or are at the beginning of their prenatal care. So next we're going to talk a little bit about syphilis. So some info on the background of syphilis. There's actually many debates as to where syphilis originated and many hypotheses. But one thing that has been consistent among all of those hypotheses is that it's been incredibly stigmatized and is considered disgraceful. It's also called a social disease or a social evil because many people were under the belief that it was spread because of prostitution. It wasn't until 1913 that a Japanese scientist by the name of Hideyu Noguchi demonstrated the presence of spirochete treponema pallidum, which is the bacteria that causes syphilis. He found that in the brain of a progressive paralysis patient. Up until this point, people were under the belief that syphilis was not real and that it was just leprosy that the patient was undergoing. So this was a really huge discovery for all of those people who were experiencing some of these CNS and neuro symptoms associated with syphilis that we'll talk about in a little bit. And then it was previously treated with mercury for many centuries, but that ended. As we know, mercury has many toxic effects to the human body. So a little info on the causative agent. It's a bacteria known by the name of Treponema pallidum. It is a gram-negative flexible spiral cell spirochete, and it is the 3rd most prevalent STI in the United States. It can be hard to isolate and find under a microscope because it can be very thin and match the refractive index of the medium. Also, fixation and staining can kill the bacteria, so dark field fluorescent or electron microscopy are used to isolate it. It has a relatively simple genome that lacks lipopolysaccharide endotoxin characteristics of gram-negative bacteria, but it contains lipoproteins that can trigger an immune response within the host. So next we're going to talk about the disease mechanism. And the bacteria functions to enter the body and moves rapidly into the bloodstream into other tissues. So it's initially transmitted from person to person via direct contact with a syphilitic sore known as a canker. So these can be found in the genitals, vagina, anus, rectum, lips, and mouth. And they're initially hard and painless, but can develop into an ulcerated sore. And pregnant women can transmit this infection to their unborn child, which can result in stillbirths or serious long-term health problems for the infant. So I want to talk a little bit more about each of these stages on the next few slides to help give you guys a better idea of how long it takes for this disease to get to those last stages. So the first stage is the primary stage, which is seen as a single lesion on the cervix, penis, or anus within 10 to 90 days of transmission. This is called a hard canker, in which side of the canker is contained a fluid that has many of the T. pallidum cells that are highly infectious. So some individuals sometimes do not notice them because they can be painless and often appear in hidden location. And these symptoms may be relatively mild, and the lesion can actually heal on its own within 2 to 6 weeks. So alongside these lesions, we also can see some localized lymph node swelling. So the secondary stage is a little bit more noticeable, and this begins once the primary canker has healed or begun to heal. It's highly contagious, and it can last 2 to 6 weeks and is reoccurrent in approximately 25% of cases. So this is characterized, like we can see on the right side here, by a rash that affects the skin and mucous membranes of the mouth, vagina, or anus. So on mucous membranes, we can see it as mucus patches or as white wart-like lesions called condylomata. So this can be accompanied with malaise, fever, or swelling of the lymph nodes. And this rash often begins on the soles of our feet and spreads to the trunk and limbs, and it can be macular or papular. So the next two stages, after the secondary stage, we see syphilis can enter into that latent period in which there are no symptoms. So during this time, our microbial levels will still remain high, and this phase can last for years. But blood testing can still detect this disease. But once we make it through the latent phase, that is when we enter the tertiary phase, and the tertiary phase can last 10 to 20 years after the initial infection. And this is when we can see these larger lesions that are deeper in size, like we can see on the right side. They're called gummas, and they may develop in a variety of locations, such as our mucous membranes, bones, and on our internal organs. And this can be cause for tissue damage. So without treatment, syphilis can continue to travel throughout the body and cause damage to our brain, our central nervous system, eyes, and ears. So I'm going to talk a little bit about those different types of severe infections. So first we have neurosyphilis on the left side. Some symptoms of neurosyphilis are severe headache, muscle weakness, and or trouble with muscle movements. Some changes to our mental state, including trouble focusing, confusion, personality changes, and dementia. For ocular syphilis, we see eye pain, eye redness, losses in vision, and blindness. And then for otosyphilis, we have hearing loss, ringing, buzzing, roaring, and hissing in ears, alongside dizziness and vertigo. So for our final diagnosis, it's often confirmed indirectly in the lab using different tests that detect for antibodies and treponemal antigens. So for treponemal serologic tests, these measure antibodies directed against T. pallidum antigens using particle agglutination, immunofluorescence, various enzyme reactions, and chemiluminescence immunoassays. And then some non-treponemal serologic tests include venereal disease research labs and rapid plasma reagent. So this test for those non-specific antibodies. So both of these tests should be used because both have limitations and can result in false readings. So the combination of both to help get a more accurate positive or negative test. So some treatment for syphilis. It is treated with peritoneal penicillin G, which specifically is a long-acting benzoyl penicillin. The exact dosage and method of injection depends on the stage you are in the disease. So if you're later in the stages, you may need a stronger dosage, and it may need to be delivered intramuscularly. And some other options include tetracyclines and doxycycline. So just wrapping up here, in 2020, 133,945 cases of syphilis were reported, and of those cases, 41,655 were in the primary and secondary stage of the disease. So this is really problematic because we're seeing a lot of newer cases. Those primary and secondary stages are days to weeks. from the initial infection, and we've seen a good chunk of those total cases being of people in those primary and secondary stages. And each year we're seeing an increase since 2000 of our overall syphilis cases reported going up. So just even between the years of 2019 and 2020, it increased by 6.8%, and we're specifically seeing the rates of syphilis increasing in men. So that brings us to the end of my presentation on trichomoniasis, syphilis, and chlamydia. If you guys have any questions, please feel free to reach out, and I can go over a couple of things with you if you have any unanswered questions. I hope that you guys enjoyed and learned a couple of things. Thanks, guys.